Mohan? Hello? 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 Can you hear me at the back? Someone, please raise your hands. Okay, thank you very much. Mohan, thank you very much for that glowing introduction. Thank you also for leaving some time for me to speak. If I can get to my slides, how do I get to my slides from here? Okay. Thank you very much. The topic on which I am speaking is electrical stimulation of the brain, clinical and basic science findings. Now I'd like to start with a few acknowledgements, and it's traditional to acknowledge one's parents who have made a lot of sacrifices. I don't know how well you can see this. Should we have the lights off and the curtains drawn? We're going to have some difficulties with later slides where I actually show you images. Well, it's traditional to start with the acknowledgements, and I'm grateful to my parents for having put up with me for the first 25 years of my life, to my teachers who have made me what I am, to the convent school and the Jesuit institutions which I attended, which shaped me and molded me to what I am today, to St. John's Medical College, which made me a doctor, to NIMHANS, which gave me the opportunity to do research, but which, as you can see, does not feed me very well, and especially to a classmate of mine, Dr. Gerard Debas. I think my batchmates over here, Dr. Mohan, Dr. Andrade, Dr. Kiran, Dr. Prakash, do you know why? Some of you know. There's a little story behind it. When I was selected to join first MBBS in St. John's back in 1977, according to the prospectus, I had until Monday to pay the fees. So I was relaxing on Friday evening, and at 4 o'clock on Friday evening, I happened to meet Dr. Gerard Debas on Museum Road. That is near Brigade Road, St. Mark's Road, Koshi's, MG Road, and so on. And this is at 4 o'clock in the evening. And we were chatting outside St. Joseph's Boys High School when he asked me, he had also got into St. John's, have you paid your fees? I said, no, I pay on Monday. He said, what's wrong with you? Today's the last day. At 4 o'clock, I was on a cycle, 6 kilometers away from St. John's. I had to get home to Victoria Layout, which was 1.5 kilometers away from there, wake up my father who was sleeping, get 600 rupees from him for my first 6 months fees. Now 600 rupees in those days was a great deal of money, and I was very lucky that my dad had that amount of cash lying around the house. And then after that I had to get onto my scooter and get to St. John's. In those days it took me 12.5 minutes to get to St. John's. Today, it's not possible to get from the checkpost to St. John's in 12.5 minutes. So, I did all that and reached here at 4:25. The cash counter had closed, but they very obligingly opened the counter to me, and 1 minute before 4:30, I paid my fees. He changed my life. So, why have I chosen this topic, electrical brain stimulation? My research interests have been very diverse. I've conducted research on subjects as varied as astrology to phenomenology of mental illness, from environmental medicine like negative ion concentration in the atmosphere and its effect on cognition, to snakebite in a study which was funded by the World Health Organization, studies on neurotransmitters in the brain, studies on drug trials in patients, studies on electroconvulsive therapy and transcranial direct current stimulation, about which I will be speaking to you, studies on a variety of herbal medicines to studies on modern medicine, studies in psychopharmacology to papers on research methodology, studies in animals to studies on human beings. The reason why I am doing so much work on brain stimulation is because my MD thesis was on electroconvulsive therapy, and once you start off on a particular field, you tend to stay with that field, and so I did. Now, over the last 30 years or so that I've been doing research, I've collaborated a lot with different departments in St. John's, with different students in St. John's, and about 40 publications have come out of this collaboration. Most of the collaboration has been with the Department of pharmacology, and recently with the Department of Anatomy. I'm focusing on ECT and transcranial direct current stimulation in this presentation because it's very appropriate. It's a collaboration with St. John's, with the Department of Anatomy, from which Dr. H.A. Mehta came. Now, there are very many different brain stimulations in neuropsychiatry. There is electroconvulsive therapy, which is the oldest. There is repetitive transcranial magnetic stimulation, which generates electric currents in the brain. There is vagus nerve stimulation, which is an approved treatment for epilepsy. There is deep brain stimulation, where electrodes are implanted in the brain and there is a stimulator outside which faces nuclei in the brain for patients with, say, Parkinson's disease, essential tremor, and so on. There is transcranial direct current stimulation, about which I will speak. Trigeminal nerve stimulation, transcutaneous electrical nerve stimulation, and very many others. There is even a journal devoted exclusively to ECT, the Journal of ECT, and to brain stimulation, a journal called Brain Stimulation. Now, ECT stands for electroconvulsive therapy, also known as shock therapy. It dates back to 1938, more than 3/4 of a century ago. It antedates the introduction of effective medications for treating mental illness. ECT is not obsolete. No matter what people think, ECT is not obsolete. It is a gold standard treatment for patients with major mental illness, particularly those with depression, particularly those with very severe depression, patients who are suicidal, patients who are catatonic, patients who with other diagnoses may be violent, and of course patients who are refractory to medications for the treatment of these conditions. ECT works faster than medicines. ECT is safer than medicines. It has fewer side effects than medicines. Patients can't commit suicide by taking an overdose of ECT. The only problem with ECT is that electricity is passed through the brain in ECT, which people don't seem to like because it makes them think of the electrical chair. And ECT causes a seizure, which people don't like because it looks very violent. And ECT in some patients can cause varying degrees of cognitive impairment, ranging from very mild forgetfulness or absent-mindedness, which is transient, to more severe forgetting of things that happened in one's life, dating back for years. Now, there are very many myths about ECT. In ECT, the brain is not zapped with enormous bolts of current. The actual current that is delivered to the brain during ECT is 800 milliamperes, and the duration for which this current is passed is very brief, something like half second to 1 second, that in most cases, and very more than that. The total charge which is delivered to the brain during ECT is in the region of 100 to 200 millicoulombs of charge, not even 1 coulomb, 100 to 200 millicoulombs, and of this charge, not everything enters the brain. A lot of it is shunted through parallel circuits in the scalp. In ECT, there is no violent convulsion, no matter what the movies show you. At the very most, there is a short jerk, or maybe a few jerks after that, because the seizure is well modified with the administration of succinylcholine or other neuromuscular relaxants. No matter what the movies show you, the patient is not conscious during ECT. Anesthesia is administered before the treatment, and there is no pain at all during the procedure or after the procedure. At the most, the patient may experience some muscular pains, but the muscular pains are more due to the succinylcholine which is administered than to the convulsion or to the ECT itself. ECT is not used as a punishment for violent or uncooperative patients. The patient does not forget who he is, no matter what the Hindi movies say. The patient does not become a zombie. The patient does not lose control of his thinking and volitional faculties. People say, we have no idea how ECT works. That's wrong. We know as much about how ECT works as we know about how drugs work. We know as much about ECT as we know about antidepressant drugs, possibly more. There is an enormous body of research which shows that ECT does not cause brain damage, no matter what the Scientology Society says. People think that ECT causes brain damage because current is passed through the brain and a seizure is elicited. ECT does not cause brain damage. There is a large body of research demonstrating this. Rather, ECT has been shown to stimulate neuroplasticity. ECT stimulates the formation of new cells in the brain, and ECT stimulates the connectivity of brain cells. This is important to its mechanism of action. Now, in this presentation, I'm going to be speaking about my work in collaboration with the Department of Anatomy in St. John's, and this work addressed the mechanism of action of ECT. Now, the brain is an organ which develops after the teenage years, and for those of you who have forgotten, this is what the brain looks like. There is a frontal lobe, a parietal lobe, an occipital lobe, and most important of all to us, the temporal lobe. Why the temporal lobe? Because the temporal lobe contains the hippocampus, which is one of only two places in the brain in which new nerve cells are formed during adult life. Here is a picture of the brain with the outer part of the temporal lobe peeled away. I do not know how well you can see this, but the blue ring in the center is the hippocampus, and the little red dot at the tip of the blue ring here is the amygdala. The hippocampus is the seat of learning and memory. The hippocampus serves a number of other important functions. Projections from the hippocampus go to different parts of the brain, including the dorsolateral prefrontal cortex, the medial prefrontal cortex, the orbital prefrontal cortex. And this is important because the prefrontal cortex is the most highly developed part of the brain, controlling the rest of the brain and controlling our behavior. The hippocampus also has projections, for example, to the hypothalamus, which regulates endocrine systems in the body, which regulates sleep-wakefulness cycles, a number of autonomic functions in the brain and in the body, and so on. Now, the number of nerve cells that we have in the brain is important to the functional integrity of the brain. There is something like 100 billion neurons in the brain, each of which synapses with an average of 1,000 other neurons. There aren't 100 billion people on this planet, and each person on this planet does not know 1,000 other people. So you can see a single human brain is more socialized than this entire planet. Just the way the number of people I know reflects my social power, reflects the number of people who can come to my assistance in times of need, so too the number of nerve cells in the brain, the number of connections from one nerve cell to another describes the social connectivity, the social networking power, and the strength of the individual neuron. The larger the number of neurons in the brain, the larger the connectivity of these neurons, the greater the cognitive reserve in the brain. So, the brain's dendritic network and synaptic connectivity reflects its functional capacity. When we experience stress, particularly when we experience severe stress, and particularly when the severe stress results in depression, cortisol increases in circulation, and the increased cortisol levels has a toxic effect on nerve cells in the brain. Now, this is an example of a normal neuron, and that is an example of a neuron in the brain of a rat which has been exposed to stress. You can see how many dendrites branch out from the normal neuron, each of which has the potential to synapse with other neurons. And you can see to what extent the dendritic arborization is diminished in the stressed animal. Now here is another set of slides which show you normal to stressed in dendritic arborization. You can see over here that each black dot represents a cell body and all the lines represent the dendrites connecting with other cell bodies. This is an example of a slide of tissue taken from a normal animal brain. Here you can see what exposure to stress does, and here you can see what exposure to extreme stress does. The number of nerve cells does not diminish markedly as a result of stress, but the connectivity between cells is markedly diminished in the stressed and depressed brain as compared with the healthy brain. Now, stress and depression are associated with decreased new cell formation in the hippocampus and a decreased glial formation in the prefrontal cortex. In contrast, stress is associated with increased cellular connectivity and activity in the amygdala. What does this mean? We know that the hippocampus is associated with learning, memory, adaptive competence, and control over the prefrontal cortex, the hypothalamus, and other parts of the brain. So, in an animal or in a human being who is stressed, decreased neuroplasticity in the hippocampus is associated with diminished cognitive functioning, but more importantly, diminished adaptive competence, impaired autonomic nervous system regulation, impaired regulation of the sleep-wakefulness cycle, all of which result in symptoms of depression. In contrast, the increased activity in the amygdala results in increased fear. The amygdala is important for fear learning. So, in stress resulting in increased neuroplasticity in the amygdala results in increased depression, increased fear, decreased confidence, and so on. There is an enormous amount of data in animal models of stress and depression and in human beings post-mortem after they die of depression or during depression. This data is obtained not only from gross anatomical studies on the size of the hippocampus, the size of the amygdala, and so on, but also from histological evidence in the hippocampus and in the amygdala. Now, what do antidepressants do? Data accumulating for the last 10 to 15 years have shown that antidepressants increase neurogenesis. Antidepressants increase new cell formation in the hippocampus. Antidepressants increase the size of the dendritic tree in the hippocampus. Antidepressants increase the formation of new synapses in the hippocampus. Antidepressants increase glial cell formation in the hippocampus. Glial cells are not connective tissue of the brain. Glial cells participate in neurotransmission, protect the neurons, are nutritive to the neurons, improve the survival of neurons, and so on. So all this occurring in the hippocampus is associated with greater efficiency of hippocampal functioning in the depressed patient and hence with recovery from depression. Now, what does ECT do? Like antidepressants, ECT induces nerve cell proliferation in the hippocampus. And we're talking about new nerve cells. ECT produces neurogenesis in the hippocampus. ECT, in fact, is the most potent inducer of neurogenesis known in research. The number of new nerve cells formed as a result of ECT increases with an increase in the number of ECT that is administered to the patient. Now these new nerve cells survive, they differentiate, and they are detectable as long after as 3 months after the last ECT. Now we know that glucocorticoids inhibit neurogenesis. ECT induces neurogenesis even in rats that are exposed to chronic hypercortisolemia, which means that ECT will produce neurogenesis even in human beings who have hypercortisolemia associated with stress and depression. Glucocorticoids also inhibit gliogenesis, and ECT promotes gliogenesis in the hippocampus and in the prefrontal cortex despite the presence of hypercortisolemia, which means that in humans who are stressed and depressed, even if hypercortisolemia is present, ECT will continue to provide these beneficial changes. ECT has been shown to stimulate vascular endothelial proliferation in the hippocampus, and these new endothelial cells which are formed provide vascular support to the new tissues, to the new nerve cells which are formed as a result of neurogenesis. Now this endothelial response to ECT occurs due to the current and the seizure and is not due to hypoxia which may occur during the seizure. Now we come to the work which we have done in the Department of Anatomy at St. John's. The guide to the 2 PhD theses is Dr. Rupa, Professor of the Department of Anatomy, and the 2 PhD students have been Dr. Khalil and Dr. Smita. Both of them have been awarded their PhDs, and papers from their PhDs have already appeared in print. Now, 2 papers by Dr. Smita, ECT and dose-dependent neuroplasticity in the hippocampus, all published ahead of print in the Journal of ECT. In this study, we examined adult male Vista rats which were treated with 6 once-daily ECT in 3 conditions: sham ECT, low-dose ECT, and high-dose ECT. The animals were sacrificed 1 month after the last ECT, and the hippocampus was studied in Smita's thesis, and the amygdala was studied in Khalil's thesis. In Smita's thesis, using light microscopy at 10 magnification, pyramidal neurons in the cornua ammonis area 1 were examined, and using light microscopy high power 40 magnification, BRDU, bromodiuridine staining in the subgranule zone of the dentate gyrus was examined. Now, basically what this means is we are looking at nerve cells over here to look at the structure of the nerve cells and the dendrites, and in this part of the study, we are looking for the formation of new nerve cells or rather new cells which take up BRDU staining. And we are looking at this not immediately after the 6 ECT, but we are looking after this 1 month after ECT, which means to say we are looking to see whether there is persistent change in these histological findings. In Khalil's thesis in the basolateral amygdala, we examined the length of the apical dendrites, the number of nodes in the apical dendrites under light microscopy at 40 magnification, and using electron microscopy at 11,000 and 30,000 magnification, we examined the kinds of synapses that were present in the amygdala. Now here is what we found in Smita's thesis. I think those of you at the back would definitely need to use your imagination to see what I am saying. I hope that those of you in front would be able to see. In this slide, animals received sham ECT. This is a representative slide of the hippocampus, the CA1 region of the hippocampus, showing dendritic arborization of pyramidal neurons. So you can see the dendrites represented by streaky lines in that slide. Now we go to an animal which has received 10 millicoulombs of charge, which is low dose of ECT, and you can see how busy the dendrites are over here. There's a lot of more streakiness, a lot of more lines that you can see. So ECT has increased the number of dendrites that have been put forth by the nerve cells in the hippocampus. And now here you see an animal which has received high dose ECT, 40 millicoulombs of charge, and the streakiness of the lines has become extremely crowded. You can see a large number of dendrites all over in the hippocampus, showing an increase in the likely connectivity of nerve cells in the hippocampus. We also looked in this thesis to see whether there was dose-dependent increase in neurogenesis, the formation of new cells in the hippocampus. In this slide, even those of you in front would need to use your imaginations. I apologize. If you can see these black dots here, the black dots are stained cells which are newly formed after ECT. There are very few of them over here in sham ECT treated animals, because even in normal persons like you and me, neurogenesis occurs and continues to occur until at least the 6th decade of life. Now here you can see animals which receive 10 millicoulombs of charge. There are many more dots which have taken up stain, cells which have taken up stain, showing that there is an increase in new cell formation in the hippocampus in animals which receive low dose ECT. And in animals which received high dose ECT, that should be 40 millicoulombs and not 10 millicoulombs. Yes, that should be 40 millicoulombs, sorry. You can see that there are a very large number of cells which have taken up staining, indicating that there are a large number of new nerve cells formed after high dose ECT. All these findings were statistically significant. To summarize this thesis, ECT is associated with a dose-dependent increase in the dendrites of nerve cells in the pyramidal nerve cells in the CA1 region of the hippocampus. It is associated with a dose-dependent increase in new cell formation in the hippocampus. We did not examine the differentiation of these cells into nerve cells versus glial cells, but there was a larger number of cells formed in the hippocampus and a larger number of dendrites formed in the hippocampus after ECT. Now, what are the implications of these findings? If the hippocampus now has more nerve cells and larger number of dendrites, this suggests that the capacity of the hippocampus for adaptive learning and coping is increased. Learning is increased, memory is increased, control over the prefrontal cortex is increased, control over the hypothalamus, the autonomic nervous system, the neuroendocrine system, all are improved, as a result of which symptoms of depression diminish, the sleep-wakeful cycle improves, the hormonal dysregulation in depression reverts to normal, control over everyday activity improves. In other words, depression remits. Now, there is some supposition that ECT producing an increase in nerve cells and increase in connectivity may result in increased interference with existing memories. After all, the hippocampus is also the seat of learning and memory is impaired in ECT. However, antidepressants also produce the same changes, and antidepressants do not produce impairment in memory except through anticholinergic action. Therefore, this mechanism is unlikely to be responsible for cognitive impairment associated with ECT, more likely to be associated with clinical improvement in depression associated with ECT. We now turn to Khalil's thesis, where we examine the effect of 6 once daily ECT on the amygdala. There are two papers, one light microscopy and the other electron microscopy findings. Let us look at the light microscopy slides first. What we saw in the case of the hippocampus was exactly reversed in the amygdala. Now here you can see an animal which received sham ECT. This is the cell body and this is the apical dendrite. Not much branching out of the dendrite here. Whereas in animals which received true ECT, you can see that the dendrites are far more busy. There's a lot more branching out of the dendrites in animals which received ECT as compared with animals which received sham treatment. Now looking at the amygdala under electron microscopy, what you will see, squares and rectangles represent excitatory synapses and circles represent inhibitory synapses. In animals which received sham ECT, I can barely see this from here, so I think you will have definite difficulty from where you are. But there are many squares and I can't see any circles in this slide. 10 millicoulombs ECT. Now there are some inhibitory synapses and there are fewer excitatory synapses. 60 millicoulombs ECT, there are a few more inhibitory synapses and even fewer excitatory synapses. So to summarize the changes in the amygdala after ECT, firstly, there were fewer excitatory and more inhibitory synapses under electron microscopy, and apical dendritic arborization was inhibited by ECT as compared with sham ECT. The net implication is connectivity in the amygdala is diminished by ECT and inhibitory activity, inhibitory synaptic activity through inhibitory synapses is increased in the amygdala after ECT. This means that high-dose ECT may correct the aberrant amygdala hyperactivation that is seen in animals or humans who are stressed or who are depressed. Humans who are stressed and depressed are anxious, afraid, depressed, angry, all of which are amygdala symptoms, and dampening of amygdala activity by diminishing dendritic connectivity and by increasing inhibitory synapses and by decreasing excitatory synapses can be expected to reverse amygdala associated anxiety, fear, anger, and so on associated with depression and with conditions like post-traumatic stress disorder in which ECT has also been found to be effective. This also suggests that ECT, particularly high-dose ECT, may obliterate the fearful effect associated with a stressor without affecting the memory of the stressor, which means the hippocampus is responsible for memory of the stressor. That is not affected. So we remember the cause of the stress, we remember the stress, but we do not remember the negative feelings, the anger, the fear, the anxiety associated with stress. So take an ECT before you go for your next viva. There is strong evidence that ECT is the most potent inducer of neuroplasticity in the brain. It reverses the impaired neuroplasticity that is associated with stress, with elevated cortisol levels which occur in depression, and these changes are occurring in critically important brain territories, important in patients with depression and allied disorders. Now we move to a second area of interest, transcranial dynamic current stimulation. I'm taking much less time in the second part of my presentation than in the first part of my presentation. because this is a very recent area of interest, only the last few years. Now, transcranial current, direct current stimulation is very different from ECT in that the amount of current that is passed through the brain is literally homeopathic. It is a brain stimulation technique involving the passage of a current ranging from 1 milliampere to 3 milliamperes through electrodes placed upon the scalp. Now you might ask, there is a scalp and the subcutaneous tissue and thick bone, thicker in men than in women. How on earth is something like 1 milliampere of current ever going to overcome such enormous resistance? I don't know the answer to that, but it does, as actually proven from evoked potential studies of the brain conducted after transcranial direct current stimulation sessions. So in transcranial direct current stimulation, tiny currents, microscopic homeopathic currents, 1 to 3 milliamperes in intensity are passed through electrodes, at least one of which is placed upon the head. It is usual for both electrodes to be placed on the head, but sometimes one electrode is placed on the shoulder or in other parts of the body. The current is direct. It's a direct current, like what you get from a battery. In fact, the transcranial direct current stimulation device is operated by a 9-volt alkaline cell, such as what you get in a cordless telephone. You may have seen that little cylindrical battery, a 9-volt battery in a cordless telephone. That is what powers a transcranial direct current stimulation device. It's a direct current, DC current with electrons flowing from cathode to anode. It's not an alternating current that you see from the electrical mains. It is an uninterrupted current, not pulsed current as in the case of ECT. The patient is fully conscious all through the transcranial direct current stimulation procedure. The patient may be sitting like you or me, sitting or standing, fully conscious. Patient can be talking, reading, listening to music or doing whatever he wants during the procedure. Now, because the current flow is continuous during TDCS, there is no depolarization cycle and repolarization cycle as in the case of ECT. No action potentials are generated. Rather, the nerve cells underlying the anode have a resting membrane potential which is closer to positive. If you remember your physiology, the resting membrane potential of nerve cells is in the negative territory, and for an action potential to be generated, the resting membrane potential must change from minus to plus.